Hello, my name is Megan Routzong, and today I'll be presenting our work on the role of endovaginal ultrasound in stress urinary incontinence assessment. The mechanisms behind both voluntary and passive closure of the female urethra and their dysfunction have been debated by researchers for decades. The existing hammock and integral theories hypothesize that downward force resulting from an increase in intra-abdominal pressure compresses the urethra against the underlying layer of endopelvic fascia. This pressure acts transversely across the urethra, forcing the anterior wall to deform towards the posterior wall, which closes the lumen and prevents leakage. Though this hypothesis has not been tested directly with mechanical studies, the success rate of the midurethral sling was universally accepted as validation. While the hammock and integral theories explain why slings can work, they do not explain why they may fail years after implantation. Increasing failure rates over time suggest that the sling's mechanical environment changes slowly after implantation, likely due to alterations in the mechanical integrity of surrounding supportive tissues. Pelvic floor ultrasound is a useful tool to visualize urethral shape and motion. We aim to use this tool to quantify the voluntary and passive urethral closure mechanisms by evaluating urethral shape and motion during squeeze and Valsalva in women with and without stress urinary incontinence. We hypothesized that dynamic ultrasound would be able to visualize these mechanisms, and that urethral shape and position measures would be significantly influenced by SUI severity. This was a prospective cohort study approved by the Institutional Review Board at NorthShore University HealthSystem. Women presenting for urodynamic study for urinary incontinence evaluation or preoperative assessment for occult urinary incontinence were recruited to the study. The first screening for exclusion criteria took place before the consent form was signed. Women with a history of surgical treatment for SUI were excluded. The second was at the end of the urodynamic study. Patients with a low maximum urethral closure pressure were excluded from the study. Recruited patients underwent a comprehensive interview, including a detailed urinary symptoms assessment and pelvic exam with POP-Q assessment. 360-degree endovaginal ultrasound volumes and dynamic ultrasound videos were taken. No preparation was required and no rectal or vaginal contrast was used. The urethral measurements were taken, and anterior and posterior urethral walls were segmented for each patient at rest, squeeze, and Valsalva. Urethral position and statistical shape measures were compared between women with no, mild, and severe SUI and evaluated across maneuvers. These images show the urethral anterior and posterior walls, outlined in yellow, used in the statistical shape model. The retropubic bladder neck angles, indicated by yellow arrows, and urethral knee pubic bone angles, indicated by red arrows, are shown at rest and Valsalva in patients with no and severe SUI. In addition to the angle measures shown, urethral lengths, diameters, and bladder neck and meatus pubic bone angles were also measured. On average, from rest to squeeze, we saw that urethral anterior-posterior diameters decreased by 4% proximally, 21% in the middle, and 32% distally. Overall, urethral length increased by 9%. The average retropubic bladder neck angle decreased by 26%, and the retropubic urethral length increased by 30%. On average, from rest to strain, we saw that urethral anterior-posterior diameters increased by 27% proximally, 23% in the middle, and 16% distally. The overall urethral length decreased by 8%. We noted an increase in retropubic bladder neck and urethral knee pubic bone angles, but a 67% decrease in retropubic urethral length. These trends were the opposite of those observed during squeeze. Only changes in position measures from rest to strain differed significantly across SUI severity groups. Retropubic bladder neck angles, infrapubic urethral length, and urethral knee pubic bone angles significantly increased with SUI severity. Urethral shapes differed significantly across maneuvers. Regardless of SUI, the urethra became thinner and more C-shaped during squeeze, and thicker and more S-shaped during Valsalva. Shape also significantly differed with SUI severity. Though we still see those C and S shapes, we can see that the urethra is proportionally thicker in women with SUI. This is mostly seen in the mid-urethra, and the effect is greater in those with severe compared to mild SUI. Our study demonstrates that dynamic anterior compartment endovaginal ultrasound can be used to evaluate urethral shape and position changes resulting from squeeze and Valsalva maneuvers and the influence of SUI on those urethral measures. During Valsalva, we observed a synchronized, though limited, inferior swinging motion of the urethra about the pubic symphysis. Patients with SUI experienced more exaggerated swinging of the bladder neck and urethral knee that resulted in proportionally thicker urethras, suggesting that controlled swinging is part of the urethral passive closure mechanism. This phenomenon is not adequately described by existing theories concerning female urinary continence. I'd like to acknowledge our funding sources and all those who contributed to this work. Thank you.